So again, huge pleasure to participate in this course again every year. Um, I was asked to give a talk about my passion, which is management of patients with spine tumors. So, Kojo, please keep me on time if I'm getting close or if I'm going over or whatever. So, just quickly to make a point, even though it's a surgical talk, anytime you're dealing with patient with spine tumors, the it's a multidisciplinary component, right? So it's the neurosurgeon, orthopedic surgeons, the medical oncologist, radiation oncologist, other surgical specialty, radiology. All of those other services are super critical for management of patient with spine tumors. So I want to emphasize that as you go to wherever it is that you go, don't approach it like like you're approaching a cervical disc or a deformity case. These are cases where you really want to identify upfront who's your colleagues in the oncology world, because a lot of these cases are personalized treatment plans for each patient. And so you can't just approach a T12 burst fracture from a renal med the same way you approach a T12 burst fracture from trauma. So if you go and you're dealing with this, if you are interested in this particular topic, we actually have a fellowship that focused on spine oncology. It's always going to be cancer-centric. We have a dedicated spine tumor multidisciplinary weekly conference where we presented these cases. And you want to make sure that when you're dealing with these type of patients, you have the ability to accommodate elective, urgent, or emergent cases at any time. So I wanted to start with some cases to give you a feel a little bit about what are the things that I deal with. And I started with this case. This is a 23-year-old female. She comes in with 1 month history of back pain. On the day of presentation, she stood up from her desk, developed immediate onset of acute back pain, subjective weakness, could not get up. She brought to the emergency room where she has mild hip flexion weakness, a sensory level at T9, neurologically intact otherwise. Again, just mild, maybe pain-limited weakness, but about 4 out of 5 hip flexion. This is the MRI, and you can see on the MRI there is something going on. There's a mild fracture at T9. There is a severe spinal cord compression. There's no cancer diagnosis. This is a patient who just showed up in the ER, and as you guys are going to go into your practices, you're going to see these type of patients show up to the emergency room, and you have to know and figure out where you're going to go from here. So if I was there, which this year I could not make it to this conference, I would ask you guys to think about which one of you, looking at this MRI on a patient who has mild hip flexion weakness, would take this patient to the operating room to do a decompression. Which one of you will not take the patient to the operating room because there is no diagnosis? Maybe it's not cancer. We don't know what kind of cancer it is. There's a lot of unknown. Do you need to embolize it? Could it be a renal met? Could it be a vascular tumor that you need to embolize prior to take this patient emergently to surgery? So you just don't know. And when you don't know, you're already in fog. So is it somebody that with mild hip weakness? Should you still take the patient to surgery because the cord is pretty much smashed? There is some more imaging. This is with contrast. Again, the tumor is not just in the canal, it's surrounding the vertebral body, is encased in tumor. A little bit more imaging here. This patient ultimately was seen by the emergency room, coverage by neurosurgery. The neurosurgeon, there was a neurosurgeon in Florida, saw the patient in the emergency room, got a CAT scan which saw a lytic lesion at T9, mild pathologic fracture at T9, and at that point he made a decision to take the patient to surgery, decompress the cord. He was not he did not feel that he would be willing to sit on somebody like that, admitting him to the hospital for a workup, considering the amount of cord compression. He did a laminectomy. No instrumentation. That's another question by itself. I'm not going to get into that. Here's what the MRI looked like after the laminectomy. And what you can see, indeed, there's less pressure on the spinal cord, but there's a lot of stuff left behind. I would say that maybe 10% of the tumor was removed, and 90% of the tumor is still there. The patient got better. The hip flexion got better. The pain got better. The patient did better immediately right after the surgery. The intraoperative pathology came back as a lymphoma. And lymphoma, as some of you may know or not, is really a tumor that can respond extremely well with non-surgical intervention. It's in many ways what I call it a medical entity disease, not a surgical entity disease. So the question that I have to you guys, now that you see this case, is if you would have known that this is a lymphoma, would you have taken this patient to surgery? The big question here was that, again, you did not have a diagnosis, right? How much of a weakness were you willing to accept taking this patient to surgery or not taking this patient to surgery? So when I give these talks, clearly by not taking the patient to surgery, there's more work to be done. You need to admit them. You need to do vitals. You need to do frequent neurological exam. You need to order a biopsy. You need to order multiple myeloma panel, PSA panel, on and on and on. And when I give these talks, this is some of the comments that I got from guys like you. They said, hey, I listened to your talk. I tried it with one patient, which means not taking the patient to surgery. Let's figure out first what it is we're dealing with. But when you admit them and you don't operate on them, there's a lot of work that you need to do when it comes to figuring out what it is. It was more work. It was less fun. I got paid less. I am a surgeon. I can get into legal trouble by admitting this patient and not taking him to surgery. So from now on, I'm going to operate on them all. That's quotes that I've received from surgeons like you who said, I'm not going to sit on this. I'm just going to take him to surgery. I'm not going to admit them and wait for the biopsy and all those things. Now, all I would say is that out of all of these comments, there is no reference to the patient itself, right? If you look at actually the comments that I've got presenting this case. So let's take the same case now. Exactly the same case. You still don't know what it is, but it's not mild hip flexion weakness. It's severe weakness in the lower extremities. So same patient, severe cord compression with a 2 out of 5 strengths in both legs. Would at that point you take this patient to surgery? Right? So how much of a neurological deficits are you willing to accept? How much of a neurological deficit are you not willing to accept? Is 2 out of 5 in both legs now making you more the opinion of taking this patient emergently to surgery or not? You still admit the patient and do the biopsy. So that is the common situation where when you don't have a diagnosis and a patient comes to the emergency room and they have some deficits, each one of you going to be in that situation, you're going to have to make a call. Am I taking the patient to surgery immediately? Am I going to wait to figure out what it is? Because ultimately, one of the things that I want to deliver through my talk here is that if there's one point that you all should take from my entire talk, is that it's always better to know what kind of tumor you operate on. Always. If you have the luxury of waiting, wait. Get the diagnosis, find out what it is you're operating on. Here is another patient, 65-year-old cervical radiculopathy, neurologically intact, no myelopathic symptomatology, and he presents with this. This was sent to me read as a meningioma, intradural meningioma. There's a dural tail there for some of the neurosurgeons in the audience. It walks, talks like a meningioma. And it's not an easy tumor to take out because the cord is draped right over it. It read as a meningioma. The patient is neurologically intact. No deficits other than radiculopathy. How are you going to do this? Are you going to do surgery? You're not going to do surgery. The reason why I'm telling you this is because this patient ended up not operated on by me immediately. We went through a workup, which ultimately included some abnormality on the smear of his blood, had a bone marrow aspiration, and it turned out that he had what we call a chloroma, suspicious for a chloroma, which is some sort of a myeloid deposit which we thought that's what it is. Now, we did not have a diagnosis, but these are super sensitive tumors to radiation. What clue us to it? The PET scan. The PET scan was super active, like lighting up like a Christmas tree. Meningiomas don't do that. Appears to be something extremely active, led to further workup. There was multiple myeloblastic cells on the bone marrow aspiration, and the thought was that this is actually consistent with chloroma. Now, what it means is that these are, with one small dose of radiation, it goes away. Is it worth doing not really biopsying this lesion? And we decided to do that. And with a small dose of radiation, look at this lesion. It just melted away. So I'm showing you cases where you may be rushed to do something, but that's why that multidisciplinary aspect is very critical. Here is another patient, 51-year-old, 1 week of foot weakness and bowel bladder dysfunction with back pain and bilateral severe lower extremity leg pains. Here is the MRI. And the MRI shows a huge sacral lesion filling up the entire sacral canal, explaining the bowel bladder incontinence, explaining the weakness, explaining the pain. All of that is explained by this lesion. The S1 nerve roots are completely engulfed with this thing. No other lesions anywhere else. CT, abdomen, chest, pelvis, everything else is negative. You do not know what this is. Are you ready to do a sacral laminectomy to decompress the nerve roots? Because the patient presents with bowel bladder incontinence, presenting with weakness, presenting with pain in order to decompress the roots. And I think that if you'll do it, the symptoms will get better because you can easily decompress those nerve roots. And that's what was done here. The patient was taken emergently to surgery that night by the spine surgeon on call. There's some more imaging here. And intralesionally, through a debulking and lumbar pelvic fixation, they found out that this was a chondrosarcoma, which is a primary bone tumor. And this was an intralesional resection for a patient with a primary bone tumor. It was the wrong surgery for this patient because now this tumor has spread everywhere and he needed an unblocked resection for this. So when they found out it was chondrosarcoma, the patient ended up getting stereotactic radiosurgery. And guess what? Surgery was great. All of his symptoms resolved, his bowel and bladder resolved, his weakness resolved, his pain got better. He was very happy for about a year. And then he came to my clinic showing me this. And he says, Dr. Mendel, I think one of my screws is backing up. I'm worried that the screw is backing up. That's what it looked like. When you look at the MRI, what do you see? You see a massive recurrence at the operative site, tumor in the canal, and that bump that you see there is actually chondrosarcoma getting ready to pop through the back of his skin. And the rod is broken. The patient did not ended up being fused. So beyond recurrence, beyond now you cannot cure this thing. In essence, you cannot do anything about this. The rod is broken. We ended up removing that bump, revise his construct. I did an unblock for the tumor that was kind of coming up into the soft tissues. There's nothing more you can do. It was really a surgery that was help initially, but then the long-term effect is that this is an uncurable disease. Here is another patient with a breast carcinoma, 2 vertebral bodies that are broken at the cervicothoracic junction. This patient was seen by a surgeon. The patient just had some neck pain. And because it was breast cancer, somewhat radiosensitive tumor, the patient ended up sent for radiation. And that's what it looks like after the radiation. The tumor shrunk, but the 2 vertebrae collapsed one on top of the other. And this was more of a mechanical instability that have progressed after the radiation. And so now you take maybe a straightforward case that you can deal with here where the neck is somewhat straight, and you're dealing up with something like this where now you got severe kyphosis, severe cord compression, and a much bigger problem. That's what I ended up doing on this. Just reconstructing the whole thing front back. Here is a patient with metastatic melanoma, and the patient had an lytic lesion in one of the vertebrae. Highly should consider this for a vertebrectomy. Instead, the patient ended up getting vertebroplasty into this vertebral body. Not only that, there was cement that was extruded into the canal, during the cement injection, and you can see it right here with further collapse, cement in the canal. Patient ended up going through a corpectomy with the reconstruction in the front. And so I'm showing you all these cases just to give you a little taste about that it's not straightforward, right? A lot of these cases, you have to make very critical decisions. And I call it the triple W, the wrong operation on the wrong patient by the wrong surgeon, right? Um, and I'm going to take it, and this is would be extreme example. This is a 50-year-old who had unresected giant cell tumor who presented with this. And what you see here is pretty much an unoperable, huge giant cell tumor that involves the sciatic notch bilaterally, the femoral heads, the entire pelvis is all chewed up. There is no pelvis. The patient is presenting with massive amount of pain, minimal movement, already incontinent of bowel bladder. If there is any movement, it's mostly some sort of a reflex, but that's about it. How you get to that point, that's another story. That's the presentation. You can see again the entire pelvis is in essence a huge giant cell tumor that's filling up the entire pelvis, displacing the bladder, the rectum, and everything else. What do you do for this? The patient is in the hospital, a massive amount of pain medication, and this is now become from an unblock option, not really there's no good unblock options here to resect something like that. You can see the MRI right here. The canal is full, the pelvis is full of tumor.
So
and look at, yeah,
just we've got four minutes.
Yeah. Okay. So I'm going to end with this case. You can see the amount of pain medications that the patient is on, massive amount of fentanyl boluses and ketamine infusion at 30 milligrams per hour. Surgical option? Well, the surgical option for pain would be what sometimes we go even further to do what we call a hemicorporectomy, right? None of you have seen it probably, but this is something that can be done on some of these big cases, and there's a lot of literature about how to do these. This is one of some of those intraoperative cases where you can see how many surgeons. It's not just neurosurgery, orthopedic. A lot of surgeons are involved with these kind of cases. There's flaps, and ultimately you perform this hemicorporectomy. But the key for our point of view was pain control for the patient. The patient did not want to go through a hemicorporectomy, but we wanted to try and get her off the ketamine fusion. And that's where the multidisciplinary becomes very valuable because cordotomy is an option to help with the pain control, right? I know you guys have not seen it, but this is something that can be considered. And what we ended up doing is a procedure called cingulotomy, where we uh, have very good functional program with pain management for patients with um, pain, and a cingulotomy is an amazing procedure, and you can see the actual procedure that was done here on this patient. And 2 weeks followed the cingulotomy, the patient was discharged on fentanyl 300 microgram patch to the skin. So I took you to 5, 6 cases just to kind of give you a little bit of a taste. Clearly, it's very difficult to cover. I know I have 4 minutes or add 4 minutes. But I kind of wanted to, I'm not going to keep going here for the sake of time, but I kind of wanted to give you a little bit of a feel for some of the cases that we deal with and some of the thought process that we go through. And again, without going into a lot of details about this, I would just stress that whenever you have the options of knowing what it is you're operating on, it's always beneficial because then everything will fall into place as to prognosis, as to um, adjuvant options prior to surgery. Those kind of options definitely would exist. Otherwise, when you don't have that option, if you have to take somebody emergently to the operating room, you're going to have to make that call. If you have the luxury of wait, get the diagnosis via biopsy. If you don't have the luxury to wait, then you don't. If somebody comes in and they are weak in their legs, then you got to take him to decompress it. On the first case that I showed with the lymphoma, I would say with a 4 out of 5 strengths, I would write it out and not operate and get the diagnosis through a biopsy. on a patient who comes in with a 2 out of 5 strengths in the legs, very weak, even if it could be lymphoma, I think it's reasonable to take the patient to surgery. The patient is very weak and the priority is to decompress the spinal cord. So by that, I'm going to end up right here just for the sake of time.
Thanks so much, Udi. It's good to see you. Any questions for Dr. Mendel? Go ahead.
Hey, Dr. Mendel, this is Hussein from Toronto. I was just wondering if you have any tips or tools that you use in situations where the patient has neurologic deficits and you want to buy some time until the biopsy is back. Do you ever use steroids, or some people talk about like a focal decompression, staying outside of the pathologic tumor and just focusing on like the healthy bone? Do you use stuff like that?
So steroids, absolutely. If you feel if you have somebody with some mild deficits, steroids would be very helpful to give you some time. And that patient will be admitted to the floor with a frequent neurological exam. And as long as they are not getting worse, and sometimes they're getting better on the steroids, I would say absolutely use the steroids. Now, steroids have side effects, especially on patients with cancer. So if they are neurologically intact, I would not put them on steroid. But if there's any ounce of deficit or something going on, and I'm deciding not to take them, and I'm going to sit on it, then I would put them on steroids. I'm not a big fan of just kind of staying out of the tumor, or I'm not sure exactly what you were referring to. But if you go to surgery to do the surgery. To do a little bit and then close and then come back to do the big surgery, I'm not a big fan of that.
Okay, thank you very much. So, thanks.